Hi guys, good evening. I'm Dr. Sandeep, your surgery guy. We'll continue our INI-CET session. Hi guys, sorry for the delay. We had an emergency that I had to look up to, so just caught up in the emergency, just finished a case. I came back as early as possible. So let's start without wasting any further time. So we'll be talking about the questions that we left across from yesterday. Question number 37. We have done 36 questions yesterday, so total of 75 is the target, right? Now we have a patient who is in severe sepsis, okay, secondary to cholangitis, has received 4 liters of crystalloids over last 6 hours. Okay, his mean arterial pressure is extremely low, but he's fluid responsive. Which of the following fluid should be given? Now I've given enough amount of crystalloids. If I continue to give crystalloids, what will happen? Because hemodilution, right? So because it's fluid responsive, I would still try to resuscitate, but this time I would use colloids, because colloids are the example of your plasma expanders. These are the examples of plasma expanders. So I don't want the the coefficient of the crystalloids to be dominant here, because it will cause hemodilution. In fact, if you give 1 ml of colloid, it will cause 1.6 ml of intravascular volume. So it is the intravascular volume. The intravascular volume that is increased is 1.6 times, right? So it is 0.6 ml will be extra here, right? So I will not give any crystalloids. So crystalloids are out of the point. So I've left out with either I can give an albumin or a dextran. Dextran is nothing but sugar, right? So rather than giving sugar, I'll give human albumin, that is 5%, which is considered to be better. So in septic shock, obviously there will be loss of, see, you need to understand, in septic shock or in sepsis, there will be damage of endothelium, right? Whenever there's endothelial damage, there will be leaky endothelial capillaries, which will cause excessive protein loss. So I have to replace that loss of protein also by giving albumin. So here the answer is going to be C for Calcutta. Now, a question number 38. I have a 31-year-old otherwise healthy male. He has brought to the hospital from a house fire. He answers the question with hoarseness of voice and has a burn to his face, chest and arms. His heart rate is 120. His blood pressure is low, respiratory rate is high, the saturation is 98 with 2 liters of nasal cannula. What is the next step in the management? Now remember, what are the danger signs or warning signs? We call it as the warning signs, or also called as indication for intubation. It is indication for intubation in burns. It is the indication of intubation in burns, right? Now, in the warning sign, number one is the voice change, that is hoarseness of voice. If there is presence of hoarseness of voice, if there is presence of stridor, that is inspiratory stridor, if there is presence of wheezing, if there is presence of wheezing, if there is presence of facial burns, if there is presence of facial burns, if it is associated with laryngeal edema, if it is associated with laryngeal edema, and if the patient is unconscious. If any one of the following is present in a patient of burns, especially the inhalation burns, these are the indications for prophylactic intubation. So here we can see very well that the patient is having an associated voice change. There's burns to his face is also there, and the patient respiratory rate is high, that is respiratory distress is noticed. So here the answer would become to intubate the patient, that is C for Calcutta, right? It is C for Calcutta. You have to intubate the patient. Question number 39, again a very important question from the INI-CET point of view. This is going to be about your pressure source, right? Now, you've been called to evaluate a sacral wound on an 85-year-old female. She has a multiple strokes, is bedbound. On her sacrum, there's a 5 into 4 centimeter area of black eschar that has no drainage. What stage of pressure ulcer it is, right? Now, we have already given the stages here. I'll quickly tell you the easy way to remember. When you say stage 1, right, in stage 1 there will be presence of non-blanching, this presence of non-blanching erythema is noticed. If there is a non-blanching erythema, this is stage 1. In stage 2 there will be partial thickness skin loss. There is partial thickness skin loss. In grade 3 there is full thickness skin loss. In grade 3 there is full thickness skin loss. There is full thickness skin loss is noticed. Grade 4 if there is involvement of underlying structure. Involving of underlying structure, that is a vessel, a tendon, a nerve, anything is involved. And the new one that you have is unstageable. Now, in an unstageable, if it is covered with, if the ulcer is covered with slough, if it is covered with necrotic patch, if it is covered with necrotic patch, or if it is present or covered with eschar, where the true depth of the ulcer cannot be assessed, we now call it as unstageable, and this is given by your National Pressure Wound Advisory Board, right? So answer here is going to be unstageable, so it is going to be D for Delhi. Yeah, right, this is going to be D for Delhi. Question number 40. Again, an interesting question. We have a 44-year-old G3P2 female. Mother was diagnosed with breast cancer at the age of 65. Now she comes to your clinic and told her most recent screening mammograph was BIRATS 3, which is probably benign. How would you counsel her? Right. Now, on the basis of BIRATS, if you have BIRATS 0, needs no further imaging, right? Incomplete. So, in BIRATS 0, we say it is an incomplete assessment. In an incomplete assessment, either the patient has not turned up with report, if the report has not been well documented, if the quality of image is poor, if wrong imaging was done, pathology was done, right breast image was done for left breast, in those course category 0, you have to repeat mammography, or I can say repeat the radiological assessment. Here you have to go with repeat radiological assessment to complete. Category 1, it is usually for screening. We say it is absolutely normal, there is no problem at all, and you have to continue the annual risk, right? Then category 2 is benign lesion, there is no risk of malignancy. Category 3 is probably benign, and when you are probably benign, it needs a follow-up after 6 months. 4 to 6 months is recommendation, because the risk of malignancy is 1 to 2%. Category 4 is suspicious of malignancy, which will require biopsy. Now your 4A, 4B, 4C, low, moderate and high suspicion for malignancy. Then you have highly suspicious of malignancy and biopsy proven malignancy. So we have a patient of BIRATS 3. BIRATS 3 is asked her to come back for follow-up after 6 months with a repeat mammograph is what is recommended in the current line of setting. Okay. Now, in 4 to 5 months later, you have to repeat the radiological assessment, not to do biopsy after 4 to 5 months, right? Again, after 6 months, we'll do repeat a radiological assessment to see if there is any problem is there or not. Okay. So, question number 41. Let's see if you're able to get this. We have a 63-year-old patient with primary hyperparathyroidism and a non-localizing studies. Undergoes a neck exploration, is found to have a normal right and left superior parathyroid glands and a normal left inferior parathyroid gland. Which of the following is the most likely location of the missing right inferior parathyroid gland? Remember, in terms of abnormalities, it will be found at the level of superior thymus, right? So basically they're asking you in terms of ectopic gland position. I've already given you that the superior parathyroid are more likely than the inferior glands to be found in the tracheo-esophageal groove, in the posterior mediastinum, or in the intrathyroidal position. The inferior parathyroid may often be found near the thyrothymic ligament and uncommonly embedded in the thymus itself. So that is why inferior always look in thymus site. Okay, question number 42, again an interesting question. Let's see. Which of the following patient with thyroid gland enlargement is least likely to have a diagnosis of thyroid cancer? Least likely. We have a 5-year-old boy with 2 family members with medullary thyroid cancer, right? Now, medullary cancer thyroids are familial. They can be seen in as early as 5 years also. In fact, 1 year is also possible. So, hence it is correct. A 75-year-old man with a solitary nodule and hoarseness of voice. When there is a solitary nodule, hoarseness of voice, that indicates involvement of recurrent laryngeal nerve, which is a malignant infiltration. Yes, this can be malignant as well. A 56-year-old woman with solitary nodule and a history of radiation to the neck. History of radiation to the neck is a risk factor for papillary cancer, thyroid. I have a 43-year-old woman with multinodular goiter and tremor. If there is presence of tremor, it indicates a toxicosis. And remember a golden rule: toxic swellings are unlikely to be malignant. They are unlikely to be malignant. Toxic swellings, they are unlikely to be malignant. Ectopic locations of parathyroid gland is important. It is important. So answer here is going to be D for Delhi. Question number 43. I have a 65-year-old female with her first post-operative visit following total thyroidectomy for papillary cancer thyroid. Okay. Which of the following features of pathology report may indicate a tumor aggressiveness and poor outcome? Right now, in terms of the outcome, toxic means hyperthyroid state. The word toxic means hyperthyroid state. Any other questions? Any other questions? Quick feedback. Okay. So talking about the prognostic statuses here. Now, in terms of prognosis to assess, we have the various criteria that you have. Number one is your ages criteria. In ages, A stands for age of the patient, G is the grade of the tumor, E is your extra thyroid invasion. E is your extra thyroid invasion. So age, grade, extra thyroid invasion, and the size of the tumor, that is your ages. Then you have another protocol that is called as the MACIS. M stands for metastasis. A stands for age of presentation. We'll say less than 40, more than 40. C stands for completeness of resection. C stands for completeness of resection. C is your completeness of resection. I stands for extra thyroid invasion. Extra thyroid invasion. S stands for size of the tumor. Okay. Now, which of the following features of pathology may indicate a tumor aggressiveness and poor outcome? Size greater than 4 centimeters, yes. Lymph node metastasis, yes. Local invasion through capsule surrounding case. All four of them are a poor indicator. So these are the indicators, right? So we say age more than 40 is poor, high grade is poor, presence of extra thyroid invasion, and size greater than 4 centimeters, right? So these are the criteria that you have to remember. Yeah, so now question number 44. We have a 55-year-old male diagnosed with myasthenia gravis, was planned for thymectomy through a cervical approach. Intraoperatively, it was noticed that a thymus had an invasion into the surrounding fatty tissue and the mediastinal pleura. Which of the following statement regarding this situation is false? Now, first of all, when we talk about the thymomas, we have a classification for thymoma. For thymoma, the classification that we use is called as Masoka classification. For thymoma, we use a classification that is called as the Masoka classification. Right now, in Masoka, they would ask you various components. Right, guys. Masoka in terms of thymoma, can anybody tell me what are the components? Important ones. Quick feedback. Quick feedback. Waiting for your feedback. Waiting for the feedback, guys. Thymomas, Masoka. Okay. See, okay. Guys, remember for thymomas, Masoka classification is important. They've asked you in your previous exam as well. Okay. Guys, I'm not able to see your chat box. Let me refresh once. 1 second. Right. Ciao. Yeah. Fine. So in terms of Masoka classification, we have stage 1 disease. In a stage 1 disease, there is microscopically, when you see microscopically, it is microscopically encapsulated tumor. Microscopically, you will notice that it is an encapsulated tumor. Macroscopically also, macroscopic also, it is encapsulated. That means it is not invading the capsule or it is not coming out of the capsule. In stage 2, there is macroscopic invasion of surrounding fatty tissue. There is macroscopic invasion of surrounding fatty tissue, of the surrounding fatty tissue. That is your stage 2. For stage 3, there has to be invasion into surrounding organs. Invasion into surrounding organs. So when I say surrounding organs, we're talking about pericardium, talking about the pericardium, we're talking about the lungs, talking about the great vessel. Now you have stage 4A and 4B. 4A is pleural or pericardial dissemination. Pleural or pericardial dissemination is 4A, and 4B, it is lymphangians, that is lymphogenous or hematogenous spread. It is lymphogenous or hematogenous spread is noted. It is the lymphogenous or the hematogenous spread, it is noticed. Okay. Now, in our context, what do you have? You have noticed the thymus had invasion into surrounding fatty tissues and mediastinal pleura, right? So, surrounding fatty tissues and mediastinal pleura. Which of the following statement regarding the situation is false? It is classified as Masoka 2. Yes, we can say surrounding fatty tissue involvement is Masoka 2. Medial stenostomy to be performed. Post surgery myasthenia gravis will not, it will improve. It will improve, it responds. Only reliable indicator of malignancy is capsular invasion in thymomas. That is also absolutely correct, right? All these statements are correct. Okay, chalo. Now, question number 45. An 83-year-old thin woman, no history of abdominal surgery, present with symptoms of a small bowel obstruction. On examination, there was pain with medial thigh rotation, and this is what we call it as the Hauschip-Romberg sign. Where do you see Hauschip-Romberg sign positive? It is seen in obturator hernia. This is seen in obturator hernia. So hence the answer here is going to be D for Delhi. As simple as that. So pain on medial rotation or the internal rotation of the thigh, it is called as the Hauschip-Romberg sign, which is positive for obturator hernia. Okay. Well. Question number 46. A 83-year-old man undergoes excision for basal cell carcinoma of the cheek. A defect of 3 into 3 centimeters in a subcutaneous fat is exposed. reconstruction of skin grafting is planned, which of the following will minimize the long-term graft contracture? Now remember, when you talk about the split skin grafting with meshing, split skin grafting will have a very high graft contracture, so this is not going to be a ideal situation. Split skin grafting without meshing with, see, meshing means you're trying to make multiple holes. If this is the split skin graft, you make multiple holes in this graft so that the graft can expand, is also called as pie crusting. This is also called as pie crusting. Either way, split skin grafting will have a very high graft contracture. Full thickness will have a minimal graft contracture. Cultured epidermal autografting is not an option here. So answer is C for Calcutta. We're talking about minimal graft contracture. Now I hope everybody knows the graft contracture of two types. We have primary contracture and the secondary contracture. Primary contracture is an immediate contracture. That means as soon as you take it from the donor side. Secondary contracture is a delayed contracture and it occurs after implanting at the recipient side. After implanting at the recipient. After implanting at the recipient. Okay. Now, what I'm telling you this is, in a split skin grafting and full thickness skin grafting, in split skin, secondary is greater than primary. In full thickness, primary is greater than secondary contracture. That is why cosmetically you will have better appearance in a full thickness skin grafting. Yeah. Question number 47. I have a 56 years old male with a history of bladder cancer and a pelvic radiation was found to have a metastasis in a previous incision, okay, on the abdominal wall and the bladder dome as well. Urologist has planned a full thickness abdominal wall resection and radical cystectomy. The abdominal wall defect is 12 into 12 centimeters and lower abdomen includes a portion of bilateral rectus abdominis. Which of the following options will provide the best abdominal wall reconstruction? The best abdominal wall reconstruction will be with a flap. And here when you talk about the flap, you have the pedicled anterolateral thigh fasciocutaneous flap, which is a combination flap. Right? Component separation will only be able to clear up a defect of 10 centimeters. If it is greater than that, you have to use a flap reconstruction. All right. So, now identify the structure marked in this inguinal hernia interview. Now this is a laparoscopic view. Let's get oriented to this. Now when you see here, this part, right? This happens to be the deep ring. This happens to be the deep ring that you're seeing here. Now if you see very carefully, there's a vessel which is present here. This is your inferior epigastric vessel. That is the inferior epigastric artery and inferior epigastric vein will run. You can see this happens to be the pubic tubercle. So I can say this is the medial side. This happens to be the lateral side. Now you can see on the medial side there is one structure which is going like this, right? And on the lateral side you can see a structure that is going like this, right? The two structures which are present. The one that is present on the medial end, this is what we call it as the vas deferens. One that is present on the lateral end, it is what your gonadal vessels are. This is your gonadal vessel. And you can see this lower part which is present, this is nothing but your peritoneal reflection. So you see the vas deferens is here. The gonadal vessels are here. And you see this is the peritoneal reflection. This is the peritoneal reflection. This is the peritoneal reflection that are present here. And this triangle that is present right in the center now. This triangle that you're seeing here, this is what we call it as the triangle of doom. This is what we call it as the triangle of doom. Right? Now the components of triangle of doom is going to be your external iliac artery. External iliac artery and the external iliac vein. Okay. This is the triangle of doom. Then if there's an extension here on the lateral side, this triangle that is present, this is the triangle of pain. So this is your iliopubic tract. Between the iliopubic tract, your gonadal vessels and the peritoneal reflection. So this continues as the peritoneal reflection. This is your triangle of pain, right? Now the structure that is marked here is your vas deferens, right? Here. So, chronic post-herniorrhaphy pain. Post-herniorrhaphy pain is defined as if a pain persists for more than 3 months even after the surgery. Now, why is that because of? Remember, it is most commonly because of it is the trapping of iliohypogastric nerve. It is the iliohypogastric nerve, trapping of iliohypogastric nerve in mesh, also called as chronic inguinodynia. It is called as the chronic inguinodynia. That is the most common nerve trapped as iliohypogastric. What is the most common nerve damage in open hernia repair, inguinal hernia repair? Most common nerve damage in open inguinal hernia repair. Open inguinal hernia repair is going to be ilioinguinal nerve. That is the ilioinguinal nerve. If I change this question, most common nerve damage in laparoscopic surgery. Most common nerve damage in laparoscopic inguinal hernia repair. Laparoscopic inguinal hernia repair. The answer is lateral cutaneous nerve of thigh. It is the lateral cutaneous nerve of thigh. This is the lateral cutaneous nerve of thigh. Right? So 3 important questions. Yes, rightly answered. That you need to remember with respect to hernia. Okay. So, question number 50. I have a 62-year-old woman undergoes a right hemicolectomy and an end ileostomy. Okay. On the right sided for perforated diverticulitis. What is the most concerning adverse outcome in a short term for this procedure and will require a revision? Remember, the most dreadful combination is going to be a stoma necrosis, right? And that stoma necrosis will require revision procedure also. It is not the skin breakdown. Stoma necrosis, yes, it's a dreadful condition. Above the level of fascia, no. It is always below the level of fascia because the fascia compresses and the vascularity below the level of fascia will decrease. So, stoma necrosis below the level of fascia will require revision. Okay, which of the following is minimal invasive technique for correction of pectus excavatum? Right now, we have, when you talk about the surgery, we have the Ravitz procedure and the Nuss procedure. Ravitz is an open surgery. Nuss is going to be your minimal invasive surgery. Clamshell is a type of thoracotomy. It is the incision of thoracotomy. In a clamshell, if this is the thorax of the patient, clamshell, you give the incision like this, right? So involving both, it's a bilateral thoracotomy. It is for bilateral thoracotomy. VAT stands for video assisted thoracic surgery. It is a video assisted. It is the video assisted thoracic surgery. It is the video assisted thoracic surgery. Okay. Now, answer here is going to be Nuss procedure. Identify the knotting technique. A quick feedback here, guys. Question number 52. Okay. Now, when you look at this, in the knotting techniques, you have the standard knots that you have to remember. You have one knot, which is going to be like this. This is what we call it as half hitch. Half hitch is an unstable knot. It is an unstable. Another one that you can see, if this is a tissue block, you have in this manner. So when you look across here, to make it more easier for you to understand, I will use a thicker color. Let's say if it is like this, right? Now all that you have to see is look at this end. This is called as a loop. This is called as the thread, right? Now you see the red thread is going under the loop. Here the red thread is going over the loop. Here the green thread is going over the loop, and here the green thread is going under the loop. So one thread is going under, one thread is going over. This is what we call it as the granny's knot. This is what we call it as a granny's knot, and this is also a unstable knot. This is also an unstable knot. We'll see one more knotting technique. Almost looks like granny, but there's a tinge of difference here. Right now here you will notice that the red thread is going under the loop. Here also it is going under the loop. Here the green thread is going over the loop. Here also is going over the loop. So either they are going under or they are going over. You can notice here, either they are going over the thread on either end, or they are going under the thread. So under the loop or over the loop, they are in the same direction. This is what we call it as the reef knot, or also called as the square knot, and this is a stable knot. This is an example of a stable, right? Now when you look across here, the last knot that is of some relevance, you will notice this will have something like this. Now here you can see we have loop 1, 2 loops, and then on top of one more loop is that 2 loops are there with the one more loop on top. And you look at the thread orientation, here the red thread is under the loop, here also the red thread is under the loop, here the green thread is over the loop, here also it is over the loop. Either it is totally under or totally over, but 2 loops are present, and this is what we call it as the surgeon's, and this is most stable. This is what we call as the most stable knot, right? So here in our image that we have, you can see this is the red loop. You see the blue thread is going under the loop. Here also the blue thread is going under the loop, right? Here the red is going over the loop. So both of them on the same direction, either they're up or down. That indicates that it is going to be a reef, or also called as a square. It is called as a reef or a square knot. Yeah. Okay. Clear, guys? See, there are other knots also, like Aberdeen's knot and all. They will not be asked in your exam. They'll ask only this. Yeah. Any questions, guy? Clear, guys? Quick feedback. Okay. So, question number 53. Again, from the surgical site infection, very, very important question. According to the Southampton wound grading system of the surgical site infection, the hemoserous discharge all along the length of the wound is classified as, right? Now, according to this, you have grade 0, which is normally healing. Grade 1, there is some amount of mild bruising or erythema is there. In 1A, some bruising is there. 1B, there is considerable bruising. 1C, there is mild erythema that is present. Grade 2, it is going to be, for grade 2, there will be presence of erythema with other signs of inflammation, right? Now, 2A, 2A at one point you will see erythema with other signs of inflammation. 2B around the sutures. 2C along the wound, and 2D around the wound, you will notice, right? Then you have the grade 3, it is clear or hemoserous discharge. If it is present at one point, that is less than 2 centimeters, it is 3A. More than 2 centimeters is 3B. Large volume is 3C. And 3D, it is prolonged, right? 3D, it is going to be prolonged, right? Now, here we say the patient is having hemoserous discharge all along the length of the wound. Hemoserous discharge all along the length of the wound, will be classified as 3B. It will be classified as 3B. Then you have complication 4 means pus at one point or along the wound, 4A and 4B. 5, it is if there is deep or severe wound infection with or without tissue loss, breaking down, or hematoma that requires aspiration. Okay. Now, let's talk about the blast injuries. Now, when you say primary blast injury, now how does this going to occur? Whenever the blast is going to occur, it is going to generate shock waves. The injury created by the shock waves is your primary injury. It is because of shock waves that hit your body, and that waves intensify in hollow spaces, hence causing damage. Secondary blast is nothing but every bomb is going to be unique, right? Few of them will have sharpnels, few of them will have metallic balls. When they come and hit you, they'll cause penetrating injuries. So penetrating injury in a bomb is a secondary injury, right? Now, what is a tertiary injury? Now, the tertiary injury is going to be from the impact itself, right? Now, what is going to happen when the bomb blasts? You're not going to stand there, right? You're going to fly and fall. When you fall, you're going to cause some amount of damage. As you fall, there'll be blunt force that is going to hit. This will result in blunt trauma. Quaternary is because of the heat. Basically, it causes burn, right? Whatever the heat generated will result in burn, and that is a quaternary burn. Okay. So primary blast is because of shock waves. So where do you have shock waves? So shock waves, I can say that it is overpressure injury, that is 2. So A is going to be 2. Penetrating injury, that is B, is going to be 3. Tertiary injury, that is C, is blunt, that is 1. And quaternary is going to be burn, right? 2, 3, 1, 4. 2, 3, 1, 4. It is B for Bombay. Yeah. Now, with respect to trauma, what is the stage 1 of damage control surgery, right? That is nothing but patient selection. Then take the patient for primary exploration. In primary exploration, the goal is to control the hemorrhage and control the contamination. Grade 3, take the patient, stage 3, take the patient back to the ICU, and then in ICU, resuscitate the patient and stabilize the patient. Stage 4, definitive. Stage 5 is your abdominal close. Now, the concept of damage control surgery is basically to prevent, it is to prevent lethal triad of trauma. Now, in the lethal triad of trauma, you have three components, right? Number one, patient will have metabolic acidosis. There will be presence of hypothermia. There will be presence of hypothermia and resulting in coagulopathy. Right? So, metabolic acidosis, hypothermia, and coagulopathy. So, answer here is going to be patient selection. C for Calcutta. Now, we have a 20 months old baby. So, when we say 20 months, I know it is less than 2 years. Right? Presented with traumatic injury to the spleen with an unstable vitals not responding to resuscitation, was planned for emergency splenectomy. Which of the following vaccine is not recommended in this setting? Right? Now, I've got it given the table. I'll give you a simplified table also. Now, when we talk about the post splenectomy vaccination, for post splenectomy vaccination, we have elective and emergency. We have the elective status and we have as an emergency status. Now, when you talk about the elective status, it should be given 2 weeks prior to surgery. We'll give pneumococcal. H influenza B, and meningococcal C. And the meningococcal C, because spleen protects from encapsulated organism. Now, when you're talking about the emergency splenectomy, the vaccine that has to be given immediate post-op. The vaccine that has to be given immediate post-operative period and in 2 weeks time. In 2 weeks post-operative. In 2 weeks post-operative. Now, in an immediate post-op, we have to give pneumococcal. Now, no matter where you give pneumococcal, remember, we'll see if it is less than 2 years of age or more than 2 years of age. If it is less than 2 years, we'll give P7. If it is more than 2 years, we'll give PPV 23. We'll give PPV 23. There is a 7 valent and a 23 valent. That is the only change. If it is more than 2 years, we'll give a 23 valent. Less than 2 years, we'll give a 7 valent, right? In 2 weeks, we'll give the meningococcal C. We'll give the meningococcal C and H influenza B. Okay. Yeah. So the question here is, which of the following is not recommended? So you have a baby less than 2 years, so I cannot give PPV 23, I'll give PPV 7. So answer here is A for Ahmedabad. Clear? Clear, guys? Question number 57. According to the NICE guidelines of CT head, okay, CT head post head injury, which among the following is not an indication to perform a CT within 1 hour of injury? Now, when we talk about within 1 hour of injury, the CT within 1 hour. Number one, if the GCS of the patient is less than 13 at any point. Second, if the GCS of the patient is less than 15 at second hour, at the second hour of status. If the patient has post-traumatic seizure, if there is presence of post-traumatic vomiting, even if there is one episode. So more than equal to one episode of seizure, more than equal to one episode of post-traumatic vomiting is noticed. If there is presence of focal neurological deficit, if there is presence of focal neurological deficit. So GCS less than 13, GCS less than 15 at second hour, post-traumatic seizures, vomiting and focal neurological deficit, right? Another one will be your depressed skull fracture. I've given it down. Presence of depressed skull fracture. If any one of the following is present, then you have to go ahead with CT within 1 hour. So GCS less than 13 is an indication. More than one episode of vomiting, yes. Post-traumatic seizures. Retrograde amnesia for more than 30 minutes is an indication for CT within 8 hours. It is an indication for CT within 8 hours. So answer here is going to be C for Calcutta. Okay. So we have a 13 years old child presented with electrical burns involving 20% of total body surface area burnt. Which of the following statement regarding the management is true regarding the fluid resuscitation and urine output according to ATL? Right now, he has an electrical burn. So when we say if there is an electric burn, according to ATLS, it is 4 ml per kg per percentage of total body surface area burnt. So here 4 into what is the weight of the patient? We have a 13-year-old child present with electric burn, 20% total body surface area. Okay, she's asking how much. Okay, so here we'll be giving 4 ml per kg, correct? Okay, okay. So let's look at the option. We'll give 4 ml per kg. That is the answer here. So C and D cannot be the answer. Ringer lactate, yes, that is the fluid of choice for the 24 hours. 1 to 1.5 ml per kg per hour is the urine output that is expected, or till the urine clears out. Till the urine clears out is a better option, because in your electrical shocks, it is associated with myoglobinuria, which will result in acute tubular necrosis. So for me to be sure, I need the urine to be cleared out. I cannot have a dark colored urine, irrespective of how much urine is produced. If the color of the urine is dark colored, then you still continue to resuscitate to avoid acute tubular necrosis. Answer here is B for Bombay. Is going to be B for Bombay. ATLS I've given you. If it is a second degree or a third degree burn, right? And if the patient is an adult or a child more than 14 years, 2 ml per kg per percentage of total body surface area burn. Child less than 14 is 3 ml. For an infant, you will add this, that is 3 ml, along with maintenance fluid is going to be added. For electrical injury and the 4th degree burns, for all ages, it is 4 ml per kg per percentage of total body surface area. Right? So this is it is. Parkland is obsolete. We don't use Parkland. Parkland causes over resuscitation. We are going to use only your ATLS protocol. Yeah. So, which category of the DCD donors, that is donation after cadaveric death, DCD stands for donation after cadaveric death, is also known as uncontrolled DCD donors, right? Uncontrolled means where you cannot predict the organ harvesting. So category 1 is what we call it as dead on arrival at the hospital. Now, how do you know whether it's a controlled or an uncontrolled donor? Very simple. Let's say you have a friend who needs a kidney and he's calling you every day, dude, can I get kidney today? You're a surgeon, right? The day you're able to tell, yes, I'll be able to give kidney today, is called as a controlled donor, and the one you are not able to predict is called as an uncontrolled donor. Now, dead on arrival at the hospital, I'm not predicting his death. I don't know when, because the patient is presented with death, so I cannot really predict when he's going to die because he's already dead. So I cannot predict this. This is an uncontrolled DCD donor. Resuscitation attempted without success. Now, when you look at this scenario, imagine you're resuscitating and then you're calling your friend, dude, there could be a possibility of getting a kidney. What does it tell you? It tells you that you are not serious about your resuscitation. We resuscitate with intent to save the patient. Here the patient has been dead. That is unpredictable. So it is an uncontrolled donor. Awaiting cardiac arrest while withdrawal of the life support. Now here you can call your friend. See, I'm going to plug a patient out. Be ready. You'll get a kidney. So this is your controlled donor. Cardiac arrest while brain dead, right? Now it's a cardiac arrest while brain dead. Patient is already brain dead, so I know there is organ available. So when there is a cardiac arrest, then you can harvest the organ, so you're prepared for it, right? It is also controlled. Cardiac arrest and unsuccessful resuscitation in hospital. So we're talking about unsuccessful resuscitation. Again, resuscitation is done with the intent of saving the patient, right? So here you could not, it is uncontrolled. So controlled donors are your category 3, category 4. So here, what is the question? Which of the following is uncontrolled? 1 to 5 is uncontrolled, right? 1 to 5 is going to be uncontrolled. C for Calcutta. Okay. Okay. Question number 60. Which of the following is not a characteristic of carbon dioxide as an insufflating gas? It is rapidly absorbable. It is inexpensive. It does not have a negligible physiological consequence. It is low risk for gas embolism, right? Now, when you say when you do carbon dioxide, when you're using the carbon dioxide to create pneumoperitoneum, the physiological implication is as you're creating the pneumoperitoneum, the intra-abdominal pressure is going to increase to 12 to 15 millimeters of mercury. Now, when there is increase in intra-abdominal pressure, they're going to compress the inferior vena cava. When the IVC is compressed, obviously the venous return to the heart will decrease, which will result in decrease in preload. If preload decreases, it will cause decrease in cardiac output. If the cardiac output decreases, it will cause decrease in systolic blood pressure. And the systolic blood pressure decreases, so obviously to compensate, the baroreceptors are going to get activated, and that is going to cause activation in the system. They will cause increase in heart rate, right? That is the first thing that is going to happen. So there is decrease in systolic blood pressure and increase in heart rate is noticed. Another one is as the intra-abdominal pressure increases, it will push the diaphragm up. Now, as the diaphragm has been pushed up, what will happen to the total lung capacity? That is going to decrease. If total lung capacity is decreased, in order to compensate that, what will happen to the respiratory rate? The respiratory rate in these patients will increase to compensate for decreased space. You see, there's a presence of physiological implications that are present. We cannot say negligible. The answer here is going to be C for Calcutta. It is going to be C for Calcutta. Clear, guys? Okay. So far, any questions? Quick feedback. So far, any questions? Quick feedback. All right. So if you have no questions, take a quick break for 5 minutes and we'll resume back with last 15 questions, right? So take a break for 5 minutes. All right, guys. So we'll talk about question number 61. It says, what is an indication for surgical repair of an aortic abdominal aneurysm? So when you talk about the aneurysms per se, now in aneurysm, we will see whether the patient is symptomatic or asymptomatic. Whether the patient is asymptomatic, that is incidentally found aneurysm, or whether the patient is symptomatic. Now, if the patient is symptomatic, then the criteria says go with repair. Now, on the other hand, if the patient is asymptomatic, then we will measure something called as a critical diameter. Called as a critical diameter. Now, we will see whether the aneurysmal sac, we'll see if the sac's diameter is less than the critical diameter, or whether the aneurysmal sac diameter is more than the critical diameter. If less than the critical diameter, then you have to go with observation. You have to go with observation. If it is more than critical diameter, then you have to go with repair. Now, to understand, we'll tell you about the critical diameters. Now, three important critical diameters that you need to know. Number one is your ascending thoracic aorta, descending thoracic aorta, abdominal aortic aneurysm. Right? Ascending thoracic aorta is 5.5 centimeters, descending thoracic aorta is 6 centimeters, and abdominal aortic aneurysm is 5.5 centimeters. Right? Now, when we say if the diameter of the sac is less than the critical diameter, we'll call the patient for observation and follow. Right? Now, in an observation, we will see what is the initial diameter of the sac. We'll see if the sac diameter, if the sac's diameter is less than 4.5 or is it greater than 4.5 centimeters. If it is less than 4.5, then we'll ask the patient for 12 monthly follow-up. If it is more than 4.5 but less than 5.5, then I'll ask for 6 monthly follow-up. Right? Now, in the follow-up, we will see something called as critical increase. Right? So, after 12 months, if there is increase in size by 10 millimeters in 12 months, this is called as critical increase. In 6 months, if there is increase in size by 5 millimeters in 6 months period, both of them are called as critical increase, and critical increase will require intervention. Okay? So this is the algorithm to be followed for your aneurysmal repair. Right? Now, which of the following is an indication? Size more than 4.5 is not an indication. Growth of more than 5 millimeters in 1 year, no. 5 millimeters in 6 months, yes. Fusiform, no. The answer is C for Calcutta. Yeah. So aneurysmal repair criteria are very, very important. Question number 62, which is the most common arrhythmia during laparoscopy? During the laparoscopy, pressure increases, vagal irritation. Vagus will cause bradycardia. So sinus bradycardia is the most common one. 63. Which of the following is the most common sclerosing agent used in foam sclerotherapy? It is your sodium tetradecyl sulfate. It is the sodium tetradecyl sulfate. And the method of creating the foam. The method of creating the foam is what we call it as the Tessari's method. This is what we call it as the Tessari's method. Right? Now, in the Tessari's method, we are going to mix air with sclerosing agent to create foam in a ratio of 4:1. In a ratio of 4:1, and this is what we call as foam sclerosing agent. So, sodium tetradecyl sulfate is the answer here. Here. Question number 64. 58-year-old female underwent mastectomy for stage 1 malignancy. During closure of the wound, surgeon encountered a following issue shown in the image and did a corrective procedure. Which of the following statement is false regarding this procedure? What is this? This is excessive. This is what we call it as dog ear deformity. This is what you call as dog ear deformity. This is most common with an elliptical incision. Now we're talking about which of the following is false, correct. Now if you give an elliptical incision, right, and if you don't close properly, what will happen at one end during the closure, as the closure occurs in one end, you will see that there'll be excessive skin, right, if you don't close properly. This is what we call as dog ear. This is correct. This condition is dog ear. It is a cosmetic defect only. Skin grafting, no, we'll only excise. You can see we have opened up, excise the redundant part. We are going to remove this end and then suture it, right? So skin grafting is not an answer. It is going to be excision. Papillary microcancer, we've already told maximum diameter of less than 10 millimeters and non-palpable. Now, we have a 30-year-old female with a dumbbell-shaped swelling that is soft, cross-fluctuant, painless in the submandibular region since 2 months. On aspiration, a thick yellow fluid was noticed. Which of the following is the false regarding this? What is this condition? This is what we call it as a plunging ranula. Right now, this arises from the sublingual glands, is correct. It is a plunging ranula. It is a mucus retention. See, remember when you talk about plunging, it is retention. In a regular ranula, it is extravasation cyst, it is retention. Cervical approach is not preferred. Intraoral approach is preferred. The preferred one for this is going to be the intraoral, right? It is going to be your intraoral approach. Clear, guys? Well, going with question number 67. Which of the following surgeries are best suited to treat carcinoid tumor of bronchus? Now, when there is bronchus, then you have to go with bronchoplastic lung resection. The answer here is going to be D for Delhi. It is the bronchoplastic lung resection for carcinoid tumors of bronchus. Which of the following statements are true regarding the image? This is what we call it as the vacuum assisted closure. This is what we called as the vacuum assisted closure. Now, the vacuum assisted closure, also called as VAC, is an old term. It is an old term. Now, the new term that we have is negative pressure wound closure system. That is NPWCS. It stands for negative pressure. It is a negative pressure wound closure system. It is the negative pressure wound closure system, right? A pressure of minus 125 millimeters of mercury is exerted. It is put as an intermittent pressure. It is the intermittent pressure. Now, what it does is it is going to increase the blood flow to the wound. It increases the blood flow to wound, and it increases cell proliferation as well. It increases cell proliferation. The greatest advantage is you have to change once in 5 days. The dressing has to be changed once in 5 days, not like a regular wound dressing where you have to do on a daily basis, right? So which of the following is, all of the following are true except you're looking for false statement. It's a continuous negative pressure of minus 125. No, it is an intermittent pressure. This is the answer. Removes interstitial fluid, increases blood flow, increases cell proliferation. All of them are correct. Right, guys? Chal. Now, which of the following represents the major cranial nerve most commonly injured during a carotid end arteriectomy? Now, when you talk about the carotid end arteriectomy, you need to understand it is not the vagus, because when you talk about the carotid artery, this is the carotid bifurcation, and this is the common carotid that is going. Now, on the posterior surface of the common carotid, you will see the vagus. This is the vagus that is going. Now, as it splits across, there's a nerve that is going to go. This is your hypoglossal nerve. Another nerve that goes here, this is your ansa cervicalis. So, when you're doing a carotid end arteriectomy, usually we incise at the level of the bifurcation, and this is your hypoglossal nerve. So, hypoglossal nerve is the most commonly damaged. This is your ansa cervicalis. This happens to be the vagus, right? So the one nerve that overrides the carotid vessel, this is your hypoglossal nerve, and that is the most commonly nerve injury that is going to happen. Right. Right, question number 70. What do you have? A 32-year-old female with a lump of 2 into 2 centimeters, with a lump of 2 into 2 centimeters in the breast on FNSC was proven to be malignancy. Okay, there were no axillary lymph nodes palpable. Post management patient expressed a desire to be pregnant. What should be the best possible advice? Now we say that, remember, whatever recurrence that has to occur will occur within the first 2 years, right? So we wait for 2 years. If there's no recurrence after 2 years, you'll advise for pregnancy. So minimum wait for 2 years, right? Because maximum recurrence occurs within first 2 years. So if there is no recurrence, it is very unlikely that it will recur for the next 3 to 5 years. Okay? So hence it is C for Calcutta. Now, we have a 55 alcoholic, 2-day history of chest pain, forceful vomiting. He was taken for OR for thoracotomy, found to have esophageal rupture, that is a Boerhaave syndrome. A jejunal feeding tube is placed, started on tube feeding on POD1. You're worried about a refeeding syndrome with severe malnutrition. What electrolyte imbalance do you expect? In a refeeding syndrome, the patient was initially starving. Now you started to give feeds. Because of feeds, there will be sudden increase in sugar, which will cause increase in insulin. Now the effect of insulin is going to be activating the sodium potassium ATPase pump. Because that the sodium will be pushed inside the cell, it will result in hypokalemia, right? So what electrolyte imbalance do you expect to see, right? Okay, so we will see number one, hypokalemia is noticed. Along with hypokalemia, you will notice that the important cofactor that you have is your phosphate, will be hypophosphatemia. Hypomagnesemia is also noted, right? So here hypophosphatemia is there, not hyperphosphatemia, not hyponatremia. Answer is hypokalemia, hypophosphatemia, hypomagnesemia is what you see. Along with that, you will see presence of thymine deficiency. There will be thymine deficiency also, right? Answer here is A for Ahmedabad. What is the side effect of mefenide acetate in burn dressing? Now, for the burn wound dressing, a quick recap. We'll talk about the topical agent. We'll see its effect on Pseudomonas. Its effect on Pseudomonas. Its effect on gram-negative bacteria. Is there any specific side effect? Or we can say, can it penetrate eschar? And is there any specific side effect? Right? These are the components that we'll look across. Now, the first topical agent that we have is your silver sulfadiazine. In fact, silver sulfadiazine is the most commonly used agent. It is effective against Pseudomonas, gram-negative, cannot penetrate eschar, no specific side effects are noticed. Right? That is your silver sulfadiazine. Then you have silver nitrate. Silver nitrate has an effective action against the Pseudomonas, little action against gram-negative, cannot penetrate eschar, but it will result in blackening of skin. So it is going to be cosmetically poor. Then you have the question that is your mefenide acetate. Mefenide acetate has a little action against these two, that is Pseudomonas and gram-negative, but can penetrate eschar, but results in metabolic acidosis, and it is extremely painful on application. So pain is aggravated. That's your mefenide acetate. The last one is going to be your silver sulfadiazine. You have silver sulfadiazine with cerium nitrate. With cerium nitrate, right? You'll see this is effective against Pseudomonas, gram-negative, eschar, but does not have any specific side effect. So the best topical agent that we have is this. Most common topical agent is your silver sulfadiazine. For mefenide acetate, we have metabolic acidosis. So here the answer is going to be metabolic acidosis. This is going to be metabolic acidosis. Now, Question number 73, which of the following statement regarding the procedure shown in the image is false, right? Now, what is this? This is your ICD placement. So you can see this is the ICD tube. In fact, this is the drain tube actually. This is the ICD. Now you can see this is the drain bag and there's a water column in it. The water column is maintained so that the air does not reflux back in. Okay. Now, where would you insert the ICD? Let's look at it. ICD insertion is anterior to mid-axillary line. We're looking for what statement here? We're looking for which of the following statement is false, right? Okay. Now, when we talk about the ICD placement, the ICD is placed in the safety triangle. Now, in the safety triangle, you'll see anteriorly it is pectoralis major, posteriorly it is latissimus dorsi. Inferiorly, it is formed by the sixth rib, and this is your mid-axillary line. We say the ICD should be placed slightly anterior to mid-axillary line, right? So your anteriorly it is formed by the pectoralis major muscle. This is your latissimus dorsi. Inferiorly it is formed by the sixth rib, right? And this is your mid-axillary line. So the statement number 1 is correct. A sharp dissection with the artery forceps down through the muscle layers of the serratus anterior and intercostal. We don't do sharp, we do blunt dissection, right? Now, tract should be oblique, you're correct. Water seal works as one-way valve is also correct. So, answer here is B for Bombay. Answer is wrongly given here, it is B for Bombay. Okay. So, question number 74, which of the following statement in the image is its appropriate statement? This is what we call as acute paranoia. Now, in acute paranoia, all that you have to do is to put a put an incision, drain the pus. So, it is paranoia, incision and drainage, and nail excision is the treatment of choice. Why nail excision? Because to prevent recurrences. Okay. So, last question in our INI-CET session. A unit of blood could be transfused most rapidly through which of the following vascular access, right? Now, when I talk about maximum flow, for a maximum flow, it should be wide bore, it should be short length. A wide bore cannula and a short length cannula will have least resistance, to blood flow or to the flow per se. Right? This is the concept that you need to follow, right? Now, let's look across here. We have the following one. Okay, we have the 7 French and an 18 gauge and a 16 gauge, right? Of all these, which is the largest one? Remember, it is the 16 gauge which is largest, right? Now, you can see 16 gauge, 3 centimeter length, peripheral IV line in right antecubital fossa. 18 gauge, not okay. 30 centimeters very long, 16 centimeters long. Shortest length is 3 centimeters and widest is 16 gauge. Answer here is D for Delhi, right? So large bore, short length. Large bore, short length will be considered as an ideal prospect for fluid resuscitation, right? So this brings down to the end of the session for your INI-CET. If you have any questions, feel free to ask. Otherwise, that's it for today. All the very best for the exam. Keep in touch, keep asking questions, keep learning. Any questions, any queries, we're always there for you. Alright guys, so can we wrap the session now here? Thank you guys. Alright, so I'll be sharing the PDF. If you have any questions, keep asking. Alright, thank you guys.